Pediatric Endocrinology, عين شمس University. It's our pleasure يا فندم. دكتورة نرمين هتتكلم عن التايتل Follow up of beta thalassemia patient in endocrinology clinic.
Thank you so much, Dr. Ilham. First of all, I would like to thank Professor Azza Abdelgawad for inviting me to speak today. It's a pleasure. I'd like to congratulate her as well as my dear sister and friend, Professor Amira Abdelmenam, for the invitation. It's an honor to speak among my esteemed professors and colleagues. I'm going to give you an overview of how we follow up beta thalassemia patients in the endocrinology clinic. Well, this is one of my patients that I first saw when he was 13 years of age. He came to me with the diagnosis of beta thalassemia major that was found out at the age of 3 years, so quite late. Splenectomized at the age of 7 years. His past medical history was complicated with a history of virus C infection that was successfully treated, and he's now on regular monthly blood transfusion in addition to chelation and other supplements, and he wanted to be evaluated from the endocrine point of view. We now know that we have thalassemia. In thalassemia, we have transfusion versus non-transfusion dependent thalassemias. Whatever the type of thalassemia is, there is a risk of iron overload, which is obviously more severe with a greater number of blood transfusions. And one of the criteria for an effective and safe blood transfusion is actually a one that ensures good growth and suppresses the intra and extramedullary hematopoiesis. And again, one of the decisions to give blood transfusion, irrespective of the hemoglobin level, is poor growth or failure to thrive. And that is because the endocrine organs are particularly susceptible to iron overload in hemolytic anemias. And the burden of iron overload is actually tremendous. The source is not only from the blood transfusions, but it can be from the gut because of excessive iron absorption from ineffective erythropoiesis. And what happens is that transferrin becomes saturated and we have surplus of the non-transferrin bound iron, which is very toxic to cells of the liver, the heart, and the endocrine glands. The body does not have the ability to get rid of the excess iron. And how we monitor the iron overload up to this moment, the best indicator of iron overload is serum ferritin. If we're going to go for the wishful thinking, then we aim for a ferritin below 1000 micrograms per liter. But I'm going to tell you that better than looking at an absolute figure of serum ferritin, it is always good to look at the trend in serum ferritin, which is even a more reliable indicator than a single value. وزي ما بنقول دايما ان الوقاية أفضل من العلاج. It is true in case of iron overload. Prevention of iron accumulation using chelation is much preferable to rescue treatment. لأنه للأسف once the iron becomes there settling in the endocrine organs, its removal is very difficult and sometimes irreversible. And the effect actually passes to every single endocrine organ in the body. Well, up to 100% of patients will develop some sort of hypogonadism at some point of their lives, not necessarily in childhood. You get around 35% having hypothyroidism, adrenal insufficiency in almost half of them. Added to this, of course, the thalassemic bone disease, the growth failure, the dysglycemia, and the hypoparathyroidism. And the sad news is that 3 of the main endocrine glands can have insufficiency either at the gland level that is primary or at the pituitary level or the hypothalamic level that is secondary. And a survey conducted in 2009 in the Middle East actually showed that around 62% of those questions of patients with thalassemia major reported that they never visited an endocrinologist, which is particularly sad. We need to evaluate this kid starting from the age of 9 years, and you need to tell them to go to the endocrine clinic at least once every year. So back to my patient, he had so many risk factors. He was 13, so he was old, he was coming late, he was diagnosed late, added to this the infection that predisposes to hypoxia and organ damage and the frequent blood transfusion. So let's see how he was doing. We always measure kids in the endocrine clinic. And so as you can see, his height was okay. His height was at -1.6 standard deviation score. He was okay in terms of height versus his mid-parental height or target range, as we call it. His weight was fine. He has not entered puberty yet at the age of 13 years, which is okay, by the way. And I'm going to move you to what we do in the endocrine clinic in evaluation of short stature. So we always think who is short and who needs to be evaluated for short stature. And we use such curves that are calibrated in standard deviation score. And anybody who's below the blue arrow, that is -2 SDS, is considered short for thinner. I know that you might use the CDC charts, which are calibrated in centiles, but be careful, Anashan. في two types of CDC charts. في CDC charts calibrated up to the 5th percentile, which we do not like, وفي others calibrated up to the 3rd percentile. And the reason is that centiles are not the same as SDS. They are not linear. While the 50th percentile is the 0 SDS, the -2 SDS, اللي هو cutoff of short stature, is actually the 2.3rd percentile. وعلشان كده بيجوا لنا ونقول لهم انتم مش قصيرين. So the first child is the child who has a height that is below the -2 SDS. The second short child, and actually the most important, is the child who is poorly growing. Because if you're looking at the height SDS, you're just taking a snapshot with your camera. But if you're looking at the height velocity, you're looking at different rates of growth, ودي الفيتشر of childhood actually. And the third, more important child even, is a child who is away from his parents. So as you can see, the mid-parental height is plotted there at the end of the slide, and this child is far away from his parents' height. More than 1.6 standard deviation difference between a child's height and mid-parental height is pathological. So this is the curve of my patient at the first visit, and as you can see, he was within the normal range, close to his parents, and his Tanner stage was 1. The clinical impression was that, well, this is a child who definitely needs to be followed up. The height seems to be okay. He might get delayed puberty, so we need to keep an eye on puberty, and more important, look at the serum ferritin. And the initial labs showed normal thyroid function, slightly deficient vitamin D, no slight dysglycemia, though it is not totally correct to use an A1C in these kids. Morning testosterone, which is a good indicator of how well the testes are doing, was good. He did not have a CBC nor ferritin. So he came back again after 5 months. Looking there, we measured him again, seemed to be okay in terms of height, but look at the velocity. The velocity was not that good. So anything less than -2 SDS is not good. His puberty actually started to kick in, his testes were growing, and his labs showed that he had a slightly elevated serum ferritin, but the rest of things were fine. So the clinical impression at that point was that his growth velocity was not satisfactory. Puberty seems to be okay. It started. We do not know if it's going to be progressing nicely or not. Everything seems to be okay except for the adrenals. And at that point of time, well, the ferritin was not okay, and the plan was to intensify his chelation and adherence, and probably he needs to be assessed for puberty and reassess growth velocity later on. So let's talk about growth in beta thalassemia. They have so many factors that adversely affect their growth. المشكلة فيهم إن هما they tend to get growth failure later in childhood and not early. So we pick them up late, especially that they have attenuated pubertal growth spurt, and if they are excessively chelated, they get disproportionate short stature. And the message is here: before embarking on assessment of growth hormone IGF-1 axis, you need to make sure that all other endocrine organs are healthy, and you need to make sure that they do not have other non-endocrine cause for short stature, particularly improper chelation. Make sure ferritin correlates with pituitary volume. So the higher the ferritin, the less the pituitary volume, and the greater the risk of panhypopituitarism. And unfortunately, these kids do not do well on growth hormone because they are resistant to growth hormone, and they are more susceptible to growth hormone side effects. What about puberty? These kids tend to have delayed puberty. That is, they do not develop secondary sexual characters by 13 or 14 if they're girls and boys. And sometimes they progress slowly through puberty, and sometimes they get arrested puberty. And that might be primary. So the gonads do not function well. بس الحقيقة ده اللي مش اللي احنا بنشوفه في الأطفال. ده اللي بيشوفه الadult endocrinologist. The more common in pediatrics is the secondary hypogonadotropic hypogonadism with low FSH and LH. And we tend to measure the gonadotrophins as well as the sex hormones, both basal and with stimulating tests. And this is what I did with my patient. Alhamdulillah, he had a good response in terms of LH, FSH, and serum testosterone. So he came back again after getting the advice of intensifying chelation therapy. And as you can see, the height was decelerating. So he was at minus 1.6 SDS, and now he's coming at minus 1.87 SDS with worsening of his height velocity. Puberty is progressing and the bone age is delayed, which is marked in yellow over the slide. And look at his TSH. TSH started to be elevated with normal free T4, and he was definitely not having the proper chelation nor the proper blood transfusion. And so the impression was that he was developing subclinical hypothyroidism with unsatisfactory growth velocity, inadequate chelation, and we needed to do more in terms of chelation. So few tips about thyroid in thalassemia. The majority develop primary hypothyroidism. 50% will have the subclinical hypothyroidism, such as this patient, which is elevated TSH, but less than 10, with normal free T4. And what you do is just follow up these patients and intensify chelation. You do not give L-troxin for these kids, except if they develop TSH above 10, or they develop, frankly, low free T4. At his last visit, he was coming at the age of 15 years and 2 months with a height SDS of -2. Puberty was nicely progressing. He managed to do better in terms of his hematology control. But look at his further growth chart. Again, the height SDS is decelerating, as you can see from the red spots, and look at the height velocity. And that is why we love height velocity curves. And as you can see, he's going down in his height velocity. He's not growing as he should be at the particular rate. TSH was doing fine. And at that point, I proceeded to evaluate his growth hormone IGF-1 axis. Why did I do this at this point? Because he was doing well in terms, or I mean, fairly well in terms of his serum ferritin. The trend was that the ferritin is going down, the hemoglobin is rising, the chelation was okay, but he was still not growing well. His velocity was decelerating. And as you can see, he was deficient by 2 provocation tests as well as by the IGF-1. And at that point, he was developing growth hormone deficiency with subclinical hypothyroidism. Just a few bits about parathyroid gland to end the loop. These kids tend to have hypoparathyroidism when they get older, and they do not necessarily develop hypocalcemia, they get paresthesia. But what is more important than hypothyroidism when we're talking about bone health is the osteopenia and osteoporosis. They have so many factors, despite of good chelation, that promote the development of osteoporosis, and that is why we have to emphasize that they have DEXA scan at least every 2 years, starting from the age of 10. And sometimes they get back pain, and at that point you need to do an MRI for the spine. What about the adrenal glands? Well, this is a bombshell. Adrenals are really dangerous. And the problem is that the symptoms of adrenal insufficiency in beta thalassemia overlap with the fatigue that develops with the anemia. And they do not tend to present with clinical adrenal insufficiency. Do not wait for them to present with clinical adrenal insufficiency and they get collapsed in Addison. They tend to have biochemical adrenal insufficiency. So you need to check it out, and they might need glucocorticoid replacement during stressful conditions, despite of not having clinical adrenal insufficiency. And well, this is my last slide. Well, just to tell you that the whole spectrum, the whole array of endocrine dysfunctions develop in children with beta thalassemia. Our patient had growth hormone deficiency. He had subclinical hypothyroidism. He probably had an element of dysglycemia, and he had vitamin D deficiency. Remember that he did not develop everything at the same time, and he kept swinging from one gland to another. So they do not have to present with everything all together, and they can present with new things over time, and some things are recoverable while others are not. Just to emphasize in my last slide that you need to send them to us, please, when they are 9, or if it could be earlier if they develop an endocrine problem. You need to do an OGT test starting from the age of 10, as well as DEXA from the age of 10. You need to assess their puberty starting from the age of 13 if it's a girl, or from 14 years of age if it's a boy. And thank you so much.
Thank you so much والحمد لله ان نهايه جلستك ابتدت مع حضور الشمس المضيئه. الاستاذ دكتور حامد شتله يضيء المؤتمر، واعتبر ان ده شرف لهذا المؤتمر. منور الدنيا كلها يا دكتور حامد. طبعا احتفائنا باستاذنا الاستاذ دكتور حامد شتلة لا يلغي الشكر الجزيل للاستاذه الدكتوره نرمين، والحقيقه ان كانت شهادتي مجروحه لكن هي احدى بناتي اللي انا اعتز ببنوتهم واعتز بان انا امهم، وده بيديني شرف. ودايما بقول ما ينفعش ان الواحد يأمل في ان حد يكون احسن منه غير ابنائه، وقد كانت هي استاذه الدكتوره نرمين
شهاده
يعني الحقيقه احييكي على التزامك بالوقت، احييكي على المحاضره الرائعه، وافكر نفسي وافكرك ان احنا من اكثر من 20 سنه واحنا بنتكلم على اللينك between endocrinal clinics and hematology clinic. ويحضرني شكري الحقيقه الاستاذ الدكتور محمد صلاح الخولي، لان هو ابتدى معانا اكتر من مش عايزه اقول 25 سنه واحنا كنا بنشتغل في هذا المجال، فيا رب الاستمرار دايما. هنقطع اتفضلي دكتوره نرمين. هنقطع الحديث الشجي بتاع هذا المؤتمر وهندخل على مرحله صغيره كده من الوفاء والتكريم العارض، لان ده لسه هيبقى